Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
What is interventional radiology? What is advanced cardiac imaging? We know that doctors can look inside of our bodies and make diagnoses with images such as ultrasounds. We know about CT scans. We know about MRIs. We're going to talk about all that this evening. But using these types of imagings, also, doctors can now use small tools like needles and tubes to do procedures or give treatments right where you need it, probably sometimes before the big stuff happens. So it's really nice to be able to do this. Often, these can be done with tiny cuts that could be small as a little pinhole, and these are less invasive procedures that can be great, especially for children, because again, today is pediatric interventional radiology. Say that 20 times really fast, I dare you. During the next hour, we have experts again answering questions about pediatric interventional radiology. And as you know, this is a live program, so think of some questions that you want to call us with us this evening. The number is 881-0013, and the lovely Miss Brenda Hernandez is going to be answering the telephones. We also want to thank the El Paso Children's Hospital, the Department of Radiology, this evening for underwriting this program, and as always, the El Paso County Medical Society for bringing the show to you. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. There's a mouthful of the topic for tonight. Again, pediatric interventional radiology, but also combined with advanced cardiac imaging. Again, both pediatrics. And this is so interesting because of the tiny tools that you guys use to help things out. With us this evening, we have Dr. Aaron Ross, who is advanced cardiac imaging, again, pediatric radiologist. That is this guy. And then you go over to this guy, and it's Dr. Chet Morthy. And he is, again, interventional radiologist, again, specializing in pediatrics. So you, right before the show started, did this great breakdown of what you specialize in, So I'm going to let you do what you specialize in, but talk a little bit, if you could, Dr. Morthy, about the breakdown of what you do, kind of all the specialists, and then we're going to talk about specific advanced cardiac imaging when we get to you.
Yeah, sure. So we already talked about how most of your audience is familiar with what radiologists do. They know that we use x-rays, CAT scans, ultrasounds, nuclear medicine, MRIs to create images of the body to help other physicians make diagnoses and then take care of our kids. Also part of radiology, and less well known by people, is that as imaging evolved, we discovered that you can do minor surgical procedures guided by images. And that technique allows you to do things with less invasiveness, minimally invasive image-guided surgery. And so that's how the specialty of interventional radiology developed. Dr. Ross and I are more interested in doing that for kids.
Right.
And so that is the subspecialty that we are developing in El Paso Children's, and that's the one that I am the most interested in, and that's the one I'm dedicated to.
See, and I'm gonna, to me, where the happiness happens on these shows is like the half an hour of us just talking. So Dr. Morthy came to El Paso in 1996. He was recruited to be here. He and his wife is a neonatologist over at the El Paso Children's. But just the idea that you have been invested from the get-go, and just the different things that you've seen in the time that you've been here, because you're looking at 15 plus years that you've been here.
25.
25? What?
24?
24, yeah, hello, 24 plus years. So, and there was also that whole process too of before the Children's Hospital was put together, and then it was a dream, and then it was reality, and then it was a dream, then it was reality. And Dr. Ross came along in 2012, and wife works at UTEP, so very, very, again, involved in El Paso. And we'll talk a little bit later, but your son benefited from El Paso Children's too. But I'd like to hold back there for a minute, because I really like it when doctors are so invested in El Paso. Even if they're not from here, a lot of them are from here, they go away, they get trained, come back. Now we have people that are here, getting trained here, staying here. Yeah. But let's talk about advanced cardiac imaging in the world of pediatrics for you. What does that mean to the people at home?
So, basically, it's a new service that we just started a couple years ago in El Paso, and most of the big cities have it. For a community of this size, about 1 million people, there's probably 10,000 children with congenital heart disease, and about 140 born every year. And what I do is I do MRI, CT, or other imaging studies to investigate that, determine what the anatomy is, and be able to tell the surgeons, the cardiologists what's going on and whether or not they need intervention. And that, like I said before, it wasn't here. So before, just to get an MRI of the heart, just to get a CT of the heart, you had to go to Houston, further away in some cases. And so that's in-house now, and we hope that now that we're doing the imaging here, we can get the surgeons, we can get everyone else in to take care of that here too. But at least now the people who have congenital heart disease, they don't have to go all the way to Houston or Dallas to get the MRI scan. They can do it at El Paso Children's. And we're the only place doing it, from Phoenix to Dallas to Houston to Mexico City. So our region is very large. There's not very many pediatric cardiac imagers, less than 50 in the world. And
So when you're talking about, and pardon my ignorance on this, when you're looking at pediatric imaging versus adult imaging. So prior to you coming along, prior to this going on, adults could get this imaging done, but children could not. What is the big difference? You know, when you're looking at it like me, it's like, oh, it's a lot smaller. But what is it that is so specialized with doing pediatric cardiac imaging?
On the cardiac side, there's a lot of differences. With you know, all of us older people, usually our heart disease is heart attack, atherosclerotic disease, you know, something causing blockages in the heart. Kids, what happens is they're born with an anomaly.
It's congenital, so it's a whole different thing you're looking for.
The diseases are more complex, actually, and they're more difficult to treat. Sometimes they're more treatable too, and so if you do intervene, you can save them. Actually, interestingly, I think for the community is actually right now I'm the only adult cardiac imager as well.
Oh my goodness.
So so El Paso Children's is actually providing imaging for, you know, select adults as well that we wouldn't have if we weren't here. So just having those very subspecialized, you know, medical practices benefits numerous populations besides the one you're focusing on. So anyway, yeah, it's been good.
It's beneficial all around. Yeah. Yes.
Well, I just want to add, the truth is, medicine has done a great job over the last history of maybe, you know, 60 years of saving babies with congenital heart disease. And these are advances in surgery, in medicine, and ICU care. We have a growing population of adult survivors of congenital heart disease. This is a really important target group. Because sure, you take care of the kid, you fix that child in early on, but guess what?
To follow.
They have complications later on. And this is actually where the bulk of Dr. Ross's work comes in, where a child may have been repaired, but now we have to monitor the child for complications, and that requires the MRI. And the MRI is done at Children's, and then the information goes to whoever needs it. We have patients who are 50 years old who had their congenital heart disease fixed in childhood, and now they're developing some later complications.
Of course,
and the decisions have to be made about whether or not a surgical intervention is necessary. And that is based partly on an MRI. And again, that adult right now, unless Dr. Ross increases the number of adults he's doing, either don't get it done or they have to go out of town.
So
and a lot of these, you have to do it every year. So you can imagine having to go to Houston every year would be a huge burden for these families that are already undergoing massive costs and medication and other things.
Well, I love what you said before the show, that the mission really is to reduce out migration, which means you want to reduce and hopefully eliminate one day people having to leave town to get things done. So we talk about congenital heart conditions. You know, what, if you could, describe some of what those heart conditions are when babies are brand new, or sometimes you know this before the babies are even born. Describe what some of those are, because I know there's a whole gamut of them.
Yeah,
or maybe
so
one of the most
I'll
common.
give you the one that I image the most is called tetralogy of Fallot. And it's where one of the arteries is kind of stenosed, the pulmonary artery where blood goes to your lungs. It's all stenosed and it's hard to get blood past it. And then the aorta
Stenosed means what, closed up?
Yeah, it's very tight. It's hard for blood to get past. Anyway, to overcome that, they do a patch. And then once you get the patch, you have to get imaged every year to see if you need a new valve put in there too, because your heart gets bigger and bigger as it's trying to, as you got blood come back into the heart because there's no valve.
Right.
And so it gets bigger. You need to know how big it is, when you need surgery again.
And describe on that note, I don't mean to interrupt, but this is always fascinating to me because our bodies know that something's going on, and so our bodies start adapting to that. So why does the heart get bigger and bigger?
Yeah,
Just physiologically, how does the heart know what to do?
Yeah, physiologically, basically what happens is you end up with higher and higher pressures in the ventricle, the squeezing part of the heart. And there's a rule called compliance where it depends on how much it's stretched and also how much pressure it's pushing against. And if it's too high, then the heart kind of gets bigger and bigger, and it's kind of slowly failing, really. And so the solution for that is just to, and now they can do it via catheter, put a valve in and stop that. But they need to know when, because you don't want to do it too early. You want to save everything till the last minute in these cases because you want to intervene as little as possible. So we have to do yearly imaging, figure out how big the heart is. And that's probably the most common thing I look at, but there's all sorts of other things. Like one of the worst ones is babies sometimes are born, like you have the aorta and you have the pulmonary artery. Aorta goes to your whole body, pulmonary artery goes to your lungs. They can be flipped. And if you have them flipped, you got to fix it within a month or two because the baby will die otherwise. And the flipping correction is very difficult, so there's a lot of things to check.
So on that note, things to check. So you're going in, you're trying to figure out, and sometimes if there's no complications during pregnancy, baby's born, goes home, seems like everything's fine, what is it that parents can see and what they're looking for when it's like, well, something's wrong, and how do you guys take it from there? Do you know we're just going to do several imaging things, and maybe the baby's just not thriving, etc. Take it from there.
Yeah, so the message here to El Paso is what we talked about earlier. Recruiting one physician like Dr. Ross who has a certain talent is not enough. You've got to put that physician in a place where you can build a team and infrastructure. And so the question you asked, the answer is, it starts with the obstetrician. The obstetrician, during the routine surveillance of a pregnancy, does an ultrasound. During the ultrasound, he or she may detect something's wrong with the heart. That results in a referral to a perinatalist who is a specialist. That perinatalist then consults a pediatric cardiologist to do a fetal echocardiogram. That fetal echocardiogram almost always gives us a pretty good idea of where we are.
Good. Okay.
That decision is made at that point is, hey, this baby needs to be sent out before delivery, or no, it can be safely delivered at El Paso Children's, or UMC, which is where we deliver our babies. Right away, we know that baby's coming. So then you need a level 4 NICU, the highest level of neonatal, highest level of neonatologists. You need the pediatric cardiologist. You need a potentially pediatric interventional cardiologist. You need a cardiac imager, and you need the nurses and the respiratory therapists and the technologists and the equipment ready to say, okay, we know what to expect when this baby is born. The baby goes to the NICU. The neonatologists are the first ones to resuscitate and stabilize the baby. So we have a level 4 NICU that have trained, qualified teams again. And the important thing here is, it's not like this physician has got his office on Viscount, this physician has his office over on the west side by No. That's not good enough. You've got to be, these physicians, this team is committed to being in the same place. So that if you deliver your baby at UMC, which by the way is the only highest maternal designation hospital in the region, okay, the safest place to deliver a baby that has complications, then it's connected to our hospital.
Gotcha.
The physicians that you need are on our campus. They're there. They know this baby's coming. So it's not a question of calling at the last minute.
Exactly.
If the baby's stabilized and needs an intervention right away, it may be from a pediatric interventional cardiologist, which we have access to in town, or it may be an emergent transport out of town, because what we don't have in El Paso yet is a pediatric heart surgery program. That is the ultimate goal that will prevent out-migration for
There's a big sigh from Dr. Ross on that. It's like, yeah, we need to get that here.
But between so between where we are now and that, there are many, many steps, honestly. So just recruiting a heart surgeon tomorrow is not going to do it. When she shows up, she's not going to have the support.
I love how you said it, when she shows up.
Oh no, she's coming.
Okay.
We don't know her name yet, but we don't. So what El Paso Children's has accomplished is the commitment. The commitment, we recruit physicians who want to be part of that team that's ready to take care of that kid and do what we can here safely. Now, The other topic we've skipped is when the perinatalist identifies abnormalities of any kind on the ultrasound, sometimes the next step is a fetal MRI. Now, this is not usually for a heart abnormality. It's for abnormalities of the brain, spine, abdomen, chest, liver, you name it. And again, we are the only ones that do fetal MRI.
Right.
So the perinatalist consults us and says, hey, I see this, this, and this, I think.
Right.
I need to clarify it. And we do the fetal MRI at El Paso Children's. Some conditions need to be shipped out of town.
Exactly. And that's what we're trying to prevent. But I see what you're saying, that's the ultimate goal too.
But most of the conditions, almost all of the conditions, are taken care of here. And that's because we have advanced surgical subspecialists. We have pediatric surgeons. We have pediatric urologists. We have a bunch of other interventionalists. But the truth is, if we don't have that fetal MRI program, again, the perinatalist is either stuck trying to make the decision on ultrasound, or, again, sending the mom out of town. And we have had moms go as far as Philadelphia to get nothing more than a fetal MRI.
Interesting.
And be told, yeah, this can be taken care of in El Paso. Well, no, we don't need to do that.
Right. So here's a question. I was going to pop over to Dr. Ross on this. So let's say right now there is someone who is 7 months pregnant, and we know that there needs to be some kind of intervention prior to getting, birthing of the child. Right now, that is an out-of-town procedure always, or is there some things that we can do? Are there some things that we can do here in El Paso?
There's a lot of things we could do in El Paso, and they tend to be more medical things like surveillance, medications, things like that. There is a new burgeoning field of fetal surgery, which is really exciting. We don't have that yet.
That fascinates me.
It's super
Just
interesting.
the fact that you can do that.
Yeah.
Well,
I don't know if you've seen those pictures where the little baby's sticking her hand through the
Yes.
uterus and grabs onto the finger. It's really cool.
Right.
They had it where I trained in Cincinnati, but we're not there yet. We're just trying to get heart surgery and stuff like that. And then, in the future, that would be amazing to get that. But right now, when we have cases that may need that, typically we're sending them to Houston.
Okay.
But
So when can you come in? So when can Dr. Ross come in and save the day? And I say that because, and you smile because we were joking about, he's the dude. And I want to say, like, from birth, like a couple of days on, what is it that has been found out? You're at the ready, like you're talking about, we know the baby's coming, the team knows the baby's coming. Right when the baby's born, Dr. Ross comes in and does, and maybe just give me a couple of examples of what you do in those situations.
Well, let's see. Something I can think of recently is there's a baby who's turning blue and breathing really hard, and they do an echocardiogram. They say something's wrong. We're not 100% sure. There's a weird artery going someplace. We're not sure what it is. We need to send somewhere, but we don't even know where to send to because we don't know what it is. So we do a CT scan. We look at it. We figure out the anatomy. We're like, okay, it's a fistula, like a connection that doesn't belong from one artery to the other. And we can say, okay, so that's what you need to fix. Then the cardiologist here, the pediatric cardiologist says, okay, I know who can fix that. I know where to send them. Let's send them to San Antonio, Houston, wherever. And so basically, for us mostly, what we do, when we do interventional, we're actually fixing people. We're helping them directly. But a lot of our work is infrastructure, is helping other doctors know what's wrong.
Exactly.
And so we're, some people call us doctors because we're the doctor that doctors see when they don't know what's wrong. And that's a lot of our business. And I would say, so the majority of my business is people who've already had the surgery. Now we just got to keep following up, seeing how they're doing. But there's a lot of babies that get born with an anomaly. We don't know what's going on. It's just very scary. They're sick. We don't know. And we do all sorts of stuff. The cardiologist does echo at the hospital. I do CT. We do lots of different things.
And so going back to Dr. Morthy then, because I know you were about to talk, so continue your thought, because obviously it was on top of his thought.
Again, we want to make sure that your audience keeps things separately. Cardiac imaging, which can lead to cardiac intervention. That step is not completely developed yet. Okay. We do have a pediatric interventional cardiologist in town, and that physician does perform significant interventions on kids. We also have a surgeon who does some surgery in the NICU when it's necessary. Sometimes it's just a matter of closing off a blood vessel that's causing the heart to work too hard. That's done in the NICU by a local surgeon. Recently, if a baby is born with a valve that's closed off and not letting blood come out, Theoretically, our pediatric interventional cardiologist can go in with a tube and use a balloon to open up the valve and stabilize the baby long enough to get the baby out. Sometimes babies are born with the arteries flipped, like you talked about. If the arteries are flipped but there's a hole in the heart, the baby's fine. But if the arteries are flipped and there's no hole in the heart, which means you got two circuits which are parallel and blood flow is not going anywhere, that baby needs an emergent procedure. And again, the interventional cardiologist comes in, goes in with a tube, and he actually tears a hole in the wall between two chambers to make a hole so that blood mixes.
Wow, that just sounds really crazy right now.
Gotta do
okay,
it.
so say that again. So because if there's a hole in the heart, it's natural because the hole's already there.
And
to
so it allows
flip.
blood to mix.
Right,
So
right.
the baby's not fine, but there's enough oxygen to keep the baby alive and not dead, not die.
Exactly, right.
But if you have the artery switched, and the right side of the heart is pumping blood to the lungs and it's coming back to the right, and the left side of the heart is pumping blood to the body but it's coming back to the
Right,
left,
It can't be.
the baby can't survive.
Right.
And if there's no hole in the heart to
Right.
let it mix, the baby's in trouble within hours. The NICU doctors can only do so much. They need the cardiologist to come in, go through the
Right.
vein from the leg, under X-ray and ultrasound, go across the wall that's connecting the two blood chambers, take a balloon and tear a hole into
So
it.
next time you guys come,
Yeah.
and I'm a big proponent of this, next time you guys come and tell your people, bring videos.
Oh, yeah.
Bring graphics, because it's so, not nice, it's a terrible word, but when you're able to visualize, when you say going into the groin, and we're talking about people this
Oh,
big,
yeah,
you
yeah,
know,
yeah.
people, but it's, again, pinholes, needles. I mean, this is just tiny, tiny
Well, so yeah,
stuff.
this is what I do, and I'll give you an example.
Okay,
That
please.
baby
Yes.
that we need that procedure on, we enter through the vein that goes to the baby's leg. We use ultrasound. That vein, by the way, when you put the little pressure on it, it collapses completely. Its diameter is maybe 3 millimeters.
Oh, dear.
Okay? So you have to get a needle to go into the vein under ultrasound, make sure a wire goes in and doesn't tear the lining, put a tube in, which can block the vein sometimes, which you have to do, have to do get to the
Right.
heart. And that can have complications in the leg, of course, but you got to pick, and you got to
Right.
do it quickly enough. So a lot of the interventional procedures we do, not just heart procedures. In fact, Dr. Ross mentioned a fistula. We had a baby last year born. The family was actually out from near Marfa,
Fort Stockton?
not Fort Stockton. What's the Fort Davis? Davis, yeah.
Okay.
They were out from the. Anyway, the baby was born with heart failure, and we couldn't figure out why. Well, after we did some imaging, we found that there was a fistula, an abnormal connection between the arteries and veins of the left arm. And the blood was
Of the
just
left
of the left arm.
So we're
The
not
left
talking
arm.
heart area, we're talking,
Well,
okay.
But normally when blood goes to the left arm, it goes through all the muscles and goes through
Right,
small vessels and comes
right.
back, and that comes back with very little pressure. But if you have an abnormal connection with the artery and vein, it's coming back fast. And then puts a lot of load on the heart. The heart fails. So once we found the fistula, that's what we did. We took the baby to the cath lab. The neonatologist kept the baby alive. I went through the little artery in the baby's belly button. Okay. Small tube goes in. Under X-ray, you put it up to the artery. You get into the artery. You put a smaller tube to that artery.
Goodness.
You make a map.
Right, right,
And
right,
then
right.
you block off the fistula. And you can block off the fistula using little metal coils. And luckily, once I blocked off the fistula, unfortunately, the little finger turned blue. And we were
Yeah.
like, but babies are amazing. They can
Right.
recover. They can make blood. That baby is awesome today. That baby's growing.
So that's the follow-up question. So growing, because we were talking about,
Yeah.
now that this is a fix,
Yeah, the fistula was fixed. The strain on the heart resolved. Now, we still needed a lot of ICU care because the heart took a lot of damage.
Right.
But the neonatologists were able to stabilize the baby. The heart slowly sort of overcame its initial damage. I mean, she won't be a concert pianist,
right?
but that baby is healthy and growing and has come back for follow-up and is doing awesome. So that's the kind of intervention that is very fulfilling to me,
Right,
right?
right.
Blocking off abnormal blood vessels. Pediatric interventional radiology deals, now both of us do, when you talk about interventional radiology, there's the hospital stuff. Sick patients in the hospital need a lot of very basic intervention. They call us to put lines in the veins when
Right.
they can't do it. When a patient in the intensive care unit needs dialysis and we need to put a temporary dialysis catheter, sometimes we'll do that. If a child comes in with a ruptured appendix
Right.
and has a big abscess, the surgeon won't take him to the operating room because that's going to be a big operation. So one of us will take him to the operating room.
So let's go there for a minute,
Yeah.
because these are the things that I wanted to talk about here, because this is pediatric, again, interventional,
Interventional radiology, yeah.
radiology, but interventional. Again, the definition of that is trying to fix things before they get really, really bad. Just
Minimally
getting in there.
invasive, image-guided surgical procedures.
Okay.
That's the, I guess, the caption, I guess.
So let's talk about this appendix.
So let's
situation
say,
here.
so
Right.
appendicitis is massively common in El Paso.
Which is crazy. I've heard that over and over again. What is it about El Paso?
I mean, there have been times when I come into work Monday and I talk to the pediatric surgeon who's been on call for the weekend, and he's told me I did 8 appendectomies this weekend. I'm like,
Is it our diet? Is it our, I mean, what
Probably,
is it about this
probably.
area?
Diet.
So the
Okay.
appendix, as you
Okay.
know,
Constipation.
appendix,
Right.
as you know, is this blinding little thing that just hangs off our colon.
Right.
Well, unfortunately, it can get blocked, and it gets blocked usually with a piece of poop that turns into a rock. Sorry, that's the best way I can put it.
No, you know what? This is what the show's about. A piece of poop that turns into a rock, because everybody can picture this. So,
Right.
and again, when you're looking at an appendix, you can live without an appendix.
Yes.
Very easily.
Yes.
So that's my question that there probably isn't an answer for. Why in El
yeah.
Paso? You were talking about constipation. We're talking about maybe our diets,
Yeah.
which is again great for everything. So we have, and this is more in children than adults. I don't hear
Absolutely, yeah.
appendicitis in adults, like rarely.
No, it's not rare.
Sometimes,
It's common. It's
yeah,
common.
but I feel
and
like it's like
yeah.
a pediatric thing.
I
big
mean, I would
time.
say the incidence of appendicitis in children is way higher than adults, but most of our adult surgeons do appendectomies.
Right.
You know, it's a routine surgery for them.
Right, right.
So again, we've got that piece of poop that turns into a rock, the appendix gets blocked.
Mm-hmm.
It's full of bugs. Now, we want to diagnose appendicitis right then and there,
Right.
but that's early appendicitis.
What are
Eas-
the symptoms, since we're on that subject? How do you
Number
diagnose?
one,
Yeah.
loss of appetite, nausea, fever, pain that starts in the belly button, but then it slowly starts going towards the right side, right lower side.
Okay.
That's the textbook. Now, if you're younger, it's hard. If it's a 18-month-old,
Because how can they tell you? They
Good
can't
luck.
tell you.
Yeah.
Right.
So we want to diagnose appendicitis then. Okay, that's an easy fix
Mm-hmm.
for the surgeon. Go in with a little scope, make a hole that big,
Right.
take the appendix out, baby goes home the next day. Unfortunately, we don't always make the diagnosis of appendicitis early in kids. The younger they are, the more often they present with a ruptured or perforated appendicitis. So you can
So
imagine.
a parent
yeah.
can't really, or at least I'm thinking, a parent wouldn't really know what to look for. And again, if you're not thinking appendicitis at all, what might the baby be presenting with that a parent can see?
Number one, belly pain.
Yeah.
Okay,
Right.
so just maybe, you know, if you're looking at a baby bowled over and rolled up, or
Doesn't want to eat.
Doesn't want to eat.
Okay.
Fever.
Okay.
That's an
Fever,
infection.
of course,
It's an
makes it-
infection.
right, right.
And tenderness in the tummy, you know.
Okay.
Now, again, it's easy to say all this stuff, but it's hard. It's
Yeah.
hard sometimes because babies a lot of times will just have a stomach bug.
Exactly.
But go
Yeah.
see the pediatrician, because they're actually very good at checking it out. And then that's when we come in, is they'll
Right.
say, okay, well, I'm not sure, I'm worried about appendicitis, but I'm not sure. And then all of a sudden you come to El Paso Children's, you get an ultrasound, and we know for sure whether or not
Right.
it's appendicitis. And sometimes it's bad news, sometimes it is appendicitis, but frequently it's not. We can reassure you, and then you don't have to worry about it.
Now,
Right.
what you said, I want to emphasize. We've already shown, and there was a study done by one of our pediatric surgeons, that first of all, we use CAT scans a lot less than other adult hospitals.
Yeah.
CAT scans are a lot of radiation. Unfortunately, adult hospitals where you're less likely to have a pediatric subspecialist, to diagnose appendicitis, they're not as good with ultrasound. They're not used to it. Your child is much more likely to get a CAT scan to diagnose it.
Interesting. Right.
If you come to
Okay.
Children's, I will tell you that 90+% of our time we diagnose not only appendicitis, but a normal appendix with ultrasound, and we hardly ever use CAT scans.
Interesting.
So that's number one that's important.
Okay.
If we make the diagnosis of
I'm gonna interrupt here,
Yeah,
just
yeah,
because
go
when
ahead.
I have a question, it's what
Yeah,
you
yeah,
say.
no problem,
When
no
you're looking at a CAT scan and ultrasound, first, let's do this. Describe what the differences are. Throw an MRI in there, because a lot of times this happens
Yeah.
with the question. So what's an MRI? What's a CAT scan? What's an ultrasound? Sound, magnetic, X-ray. So
I'll let the engineer here
Yeah,
finish
okay,
it.
engineer.
Let me do it.
All right,
Okay,
Dr. Ross,
so-
go, Dr. Ross.
Yeah, ultrasound uses sound waves, and it's like you see with the new unborn babies, you know, that grayscale picture. It's kind of hard for people who haven't been trained to understand what it looks like. But it's fast, no radiation, and cheap, relatively, compared to the other modalities. Now, CT is basically an X-ray, but in a circle. And so you spin the X-ray all the way around the patient, and then you use a computer to calculate what all of that looks like. And so it's a 30-second scan, and you see everything in 3D, like the belly, if you're looking for
Right.
appendicitis.
Okay.
MRI is a totally different thing. Now you're using radio waves.
Right.
You go into this big, long tube, you're in there for an hour, and it's very noisy.
Everybody loves it.
Yeah, yeah.
Oh.
And it's very noisy, and it takes forever. But it's amazing for what it does, because it lets you see soft tissues really well. So it's like someone's having seizures. You can see little bits of the brain that are wrong. Or in pregnant women who may have appendicitis, you could look at the appendix without messing with the baby, you know, without giving radiation and stuff like that. So each modality has its own use. the great thing about El Paso Children's and children's hospitals in general is we focus on ultrasound, we focus on MRI, we
Nice.
avoid CT, we try to get the lowest amount of radiation possible. And that's what Dr. Morthy was saying is that, and that's why when I was worried if my kid had appendicitis, I went to children's because
Right.
I could look at it with ultrasound.
So on that note, we talked a little bit before the show, and your young one, when he was 7,
Yeah.
had an issue, and you said you were cool to talk about it. So
Yeah.
talk about what issue your son had, and what happened at El Paso Children's.
So yeah, I don't like reliving it, but I love telling about it because it's important for people to understand that we don't just talk about
Yeah,
children's
exactly. It's a
hospital.
relatable thing. If it's something
Yeah.
that happens to you, and we talked about this before our show too, and I keep saying that, but when you guys become people is when you're on this table. You know, a lot of times doctors are doctors and people kind of glaze over when you talk because he's the doctor. What did he say? I don't know. Did you remember what he said? I don't know. But here, you guys are people.
Yeah.
And so when they know that you had a son that had an issue and you took him
Yeah.
somewhere, it's like, oh, he's a dad too? That's right, he's a dad.
Yeah.
So right now, you're a dad. You happen to be a doctor, but you're a dad.
So yeah, so I'd been here about a year, and I woke up and started working, and at home, and my son woke up, and my wife started screaming that he couldn't talk, couldn't walk, he was throwing up, acting real weird, scared the crud out of me.
And he's 7.
He's 7, and so I ran into the room, saw him, and he was acting just really, really weird, and then I kind of started to recognize that he was probably having a seizure, but he had no history of seizures, nothing like that. This is a very scary event. We called 911. I called Dr. Morthy, and we got him in an ambulance and brought him to the West Side Hospital, and then got him transferred to Children's. And it turned out he had meningitis.
Oh.
And it was extremely scary.
Oh.
We were in the hospital for a month, but
You were in the hospital for a month.
yeah, but I really credit, obviously the doctors, like Dr. Morthy. He actually helped diagnose what the ultimate problem was. But I really credit all the physicians working there with saving my child. And that is the beauty of having a children's hospital, is there's somewhere where people know what it is that kids get wrong. They know how to deal with kids when they have a hard IV, when something's wrong. And so we didn't have to go out of town. And before I came here, I was working in Amarillo. And if I'd been in Amarillo, I absolutely would have had to leave town. We would have been on a plane to Dallas. And who knows what would have happened in the plane. And so I'm a huge believer in El Paso Children's. I'm all in on the hospital. And I'm really grateful that the community not only came together to make the hospital, not just a place for me to work, but a place for my family to be safe.
Exactly.
And so I think it's important that people understand that I don't just work at Children's, I bring my family to Children's, and I trust it. And so it's just a beautiful resource to have in El Paso, and every day we see miracles that really wouldn't happen if we didn't have the hospital. And it's what Dr. Morthy's saying is you need a coalescence of medical specialists, like a big group where we can all talk. And I can't tell you how many times I've heard something get solved in the doctor lunchroom, or something like that.
In oncology, we call it the tumor board, right? Where everybody gets together and they talk about that. And I'm glad that your son's doing well today.
He's
a healthy,
perfectly
bouncing
fine.
teenager.
Everything came out okay. He
Nice.
got the antibiotics and everything. He's perfect now.
So on that note, antibiotics, that makes me think that's a bacteria meningitis, because there's also viral meningitis. But I'd like to bring that same story, Dr. Morthy, to you. What is it that you were looking for? How did you find out what?
Well, I mean, I want to make sure everybody understands. First of all, the pediatric intensive care doctor. Our children's hospital committed a long time ago to making sure that there is a pediatric intensive care doctor 24/7 in the hospital.
Nice.
Yeah.
Key,
Yes.
absolutely key.
Right.
Other doctors that were involved in taking care of his son, the neurologist, the pediatric neurologist. We had a pediatric infectious disease specialist. My expertise in that case was my experience with pediatric neuroradiology. It was an infection. It was an infection that came from a particular place. But then more importantly, after the initial infection was treated and he didn't respond the way we expected, something else was going on. And it really was the MRI in this case that showed us, hey, another thing that's going on is maybe his immune system is reacting to the infection in a certain way
Right.
and causing a second problem. Now that is a very unusual complication. Okay, and to recognize that, you just need to be doing pediatric radiology
Yeah.
all the time.
Yeah. Have that experience of it.
That's what I'm. If he hadn't been focused on peds, if the PICU doctor hadn't been focused on pediatrics, this could have been missed so easily,
Right.
so easily. And and sometimes we see people come from other cities, little towns and stuff where everyone does the best they can, and they get generally good care. Some things get caught at the large
Right.
city pediatric hospital, and it's just because that's what we do.
It's the volume. It's the amount of people that you have coming in. Again, the mission is to reduce out migration so that when people are here, you all see everything that you can see, and if we're able to fix it here, we're able to fix it here. I love that story. And I've got some questions here from the audience. So what I'm going to do, because time is going fast, you guys are fast. So Brenda, thank you very much. We have a question here from the audience. Son had open heart surgery. So let me first do the disclaimer. Yeah. All that we have is what we have from the questions here. So Brenda writes it down. We don't have extra information. So do the best that you can with the information I give you.
Yeah.
Son had open heart surgery at age 9 to close a hole in the top part of his heart. How have materials changed from before to now when doing the same surgical procedures? So it doesn't say how many years ago he was 9, but maybe we can talk a little bit about that. And Dr. Ross, would I be sending that your way?
Yeah.
That question?
Yeah.
Okay, great.
So materials have changed a lot since over the last couple decades, since I did med school. Basically, we've developed better and better plastics that the body recognizes and doesn't reject. And then recently, we've even developed ways to insert into the plastic certain medications, like medications that keep arteries from closing up or keep clots from forming. And so
So as the plastic is built in whatever factory
Yeah.
it's being built in, there's medication put in there
Put
so
in
it
it.
constantly emits this
Exactly.
medication inside the body.
Yeah.
Wow, that's cool. Okay.
And it's one of the most interesting fields going forward is biological devices. And we live in an amazing country right now because America is the leader in developing medical devices, and we want to make sure El Paso has access to all of that.
I'm going to guess, based on
Yes.
the description, that this baby had what's called an atrial septal defect. And what that means is,
Look at you, fancy pants.
no,
Yeah,
what
say,
that
say
means
that
is
slowly.
the two
Atrial?
atrial septal defect.
Okay.
The two smaller chambers of the heart have a separation of a wall, and some babies are born with a hole in that wall.
Right.
Back in the day, a surgeon would have to put the baby to sleep, open up the chest, open up the heart, stop the heart,
Oh my gosh.
and sew the hole up,
Right.
close back, start the heart again, and that was open heart surgery for ASD closure. That is very,
Huge.
very rarely done now.
Yeah.
So we talked about the pediatric interventional cardiologist. That is now done through a tube that goes through your vein from your groin.
So explain the procedure to where a second grader can understand that. Again,
Sure.
next time
Now, I'm
you
not-
guys, next time you're bringing graphics. Next time
Now,
you
I'm not
guys
the
have
one
to
that does
bring-
this, but there is a guy in
Okay.
town that does it.
All right.
But he does it with another cardiologist who first of all puts a probe, an ultrasound probe down the baby's esophagus right behind the heart so
Okay.
they can see the two chambers and the hole in between.
Gotcha.
Then the interventional cardiologist goes through the vein from the leg, goes in with the tube, right? Goes across the hole where these two
Right.
chambers are, makes some measurements because there's another big vessel that's coming out this way. They need to make sure they don't clamp off. Based on the measurements and based on the anatomy, he or she can deploy a device through the tube. And that device can look like a
plug.
little clamshell.
Yeah, a little plug.
So it's a little clamshell or plug where he goes across, opens up one part of the clamshell, pulls back, opens up the other part of the clamshell, which are connected, like a little sandwich. The hole is closed. You pull out the tube from the groin.
The plug stays in
The plug stays in,
for the
and the
rest
hole
of
is
this
closed.
child's life.
The rest of the child's life.
Okay.
Baby goes home.
Okay, so my follow-up question there is,
Yeah.
baby's this big.
Yep.
When baby gets this big,
a
when
good
baby
question.
becomes 6'2".
Yeah. That's
a great
and so,
question.
Dr. Ross, let's go to you because, and you were talking about this
Yeah.
earlier too, you fix things, you monitor, every year you look at something else. Somewhere along the way, this little tiny clamshell, unless it's elastic or whatever, and this is where you come in. Where, again, you look every year, but how often and when along this baby's life will
Yeah.
that need to be looked at again?
So yeah, I mean, it kind of depends. They even with the plugs we're talking about, they will do follow-up imaging, and occasionally, and usually with ultrasound, usually it's the cardiologist. But if they have any question, like maybe there's a leak around it, or like there's some symptoms, like they're getting tired early or something, they'll check it out then, and then they can decide what to do at that point. But like in the case of this child, like even though maybe this happened a while ago and they got older devices or whatever, still they're going to benefit from the newer diagnostic techniques now. And if something does have to be done in the future, they're going to benefit from the newer materials too.
So the parents just know, and this child knows, and I'm thinking a couple of days, couple of months, whatever old. So as the parents age, as a child ages, how's the question I'm trying to think of here? Sports, you were talking about a person won't be able to be a concert pianist. Maybe she will. Just
Maybe
saying.
she will.
Maybe she will. And there's different options of what we can go to right now. But what is it that will keep children from thriving physically? Like what congenital issues are they born with? But yes, we're able to fix them, but still not fixed enough because biology and
so this
God intervening, all that stuff. What are some of the
them
most?
are cardiac. Some of them are going to be things he does.
Yeah.
Okay.
But this particular one that we're guessing
Right.
from your audience member
Right.
is actually a one-stop fix for the most part. That hole doesn't get bigger. So that little clamshell stays there.
As the heart grows.
Yep, and the hole is closed forever.
Okay.
Almost never does anything have to be done. And the fact that it was done when he was 9 sounds about right. It doesn't get the baby into trouble early on.
Okay.
So it can cause some pressure problems later on, and they fixed it around the age of 9. That sounds about right for back then. I don't know how long ago that was.
Right.
And right now, it's not something that would be done as soon as the baby was born at all. Because sometimes these little holes close by themselves, so you give them a shot. But if it's a true atrial septal defect, today it'll be closed by an interventional procedure by the interventional cardiologist.
So when you say sometimes we wait for the hole to close on its own, what is happening again physiologically around that heart? What problems is that hole causing right now? Before you guys do we wait several weeks? Do you wait several months to see if that hole starts closing? What are you looking out for in between?
Yeah, this gets complicated and probably a question that you should direct to your next pediatric cardiology guest.
Okay.
But broadly speaking, the ASD won't get into trouble. But there are two larger chambers at the bottom of the heart, which are big muscles. If they have a hole in between, we're talking about the major pumping chambers of the heart. You want each chamber to only pump blood, this one to the lung, this one to the body. But if there's a hole in between, they're both pumping blood to both. And that is too much work.
You need to
and
fix that
the
right
muscle
away.
will fail. Not right away. A lot of them close by 6 months, depending on how big they are, depending on how much flow is going across. So the cardiologist can follow this with the ultrasound, the echo. But at some point, if it doesn't close, it's open heart surgery, or nowadays, it's through the tube, and they can put a closure device across that hole, depending on the anatomy of it, of course, and avoid surgery, avoid open surgery.
So for those 6 months, what is the baby going through? What is mom and dad looking for? Baby sleeping, this and that and the other?
Yeah.
You go to the
At that
hospital.
age, all you care about is the child feeding and gaining weight.
Gotcha.
So the big signs for congenital heart disease when the child is young, you know, let's face it, you can't do too many tests. You can't see if they can run up a flight of stairs.
Exactly.
So the best signs for the cardiologist, and the pediatrician can do this, is the baby gaining weight, he's able to feed. A lot of babies with congenital heart disease that don't need surgery right away, guess what? They get tired just feeding. So then the GI doctor gets involved. They put a tube in. The babies sometimes have tubes in their stomachs for months just so we can give them nutrition to grow because they get tired trying to feed. And then you fatten them up, get them to a certain size based on a certain weight. That's when the cardiologist and the surgeon can do the surgery, right?
Okay.
So yeah, this is a complex field.
No, it is, and that's
Yeah.
why we could do 15 hours on this. I have another question here from the audience. Dr. Ross, I'm going to pass this on to you because we were talking about the different types of imaging. This isn't necessarily pediatric, but the question is, can you take an MRI or can somebody take an MRI when you have titanium hardware? And so we were talking about different tests and what they do. Question is, which scan methods can be used with titanium hardware? So that's the question for the audience.
Yeah, that's a great question. We come up against this all the time. Titanium, most titanium hardware you can put into the MRI, but it ruins the image because you're sending radio waves and receiving radio waves. As you can imagine, this big long antenna is sucking them up, and it makes the image look real cruddy. It's hard to see anything. So then you could try CT. CT is also hard because the X-rays have a hard time going through the metal, so you get these streaks coming off of it. If you have hardware, there's kind of that's when it's really important to involve your radiologist and have the doctor talk to the radiologist, because you got to come up with the best solution you can. And there's no ideal solution. Ultrasound, as long as you're not trying to go through the metal, you can do.
Right, right.
But CT and MR are definitely affected by metal of any kind.
Now, I just want to make sure, I don't know if the audience member is asking, can you go into an MRI unit with titanium hardware somewhere else? Let's say we're trying to image the brain, but they might have a titanium valve.
Right.
Yeah.
Now,
Okay.
we have a resource in the hospital, and most patients who have, let's say, a heart valve, most of the time the parents will carry around a card telling
Right.
you exactly what kind of valve it is. And we can look it up. Every one of our MRI technologists knows how to look up, oh, this valve, is it safe and compatible for MRI? Now, that means it's safe for them to go in. Now, we're not going to image the heart.
Right.
Because we can't, like he said, the titanium, but we can image the brain.
Right, and it wouldn't affect the imaging
right.
of the brain.
So
Okay.
yeah, so if they're asking whether or not they can even go into MRI, that you have to check. You got to get the literature on your device, and then that'll tell you if it's safe. And then sometimes it'll tell you how strong of a magnet you can go into.
Okay. All right. We are not like closing down the show, but we're like at 13 minutes, and you guys have a lot going on. So
Yeah.
what I'd like to do is stop questions from the audience for a few minutes and talk about what either we haven't covered yet that you really do want to cover, or if there's something that we did talk a little bit about that you want to expand on. But I think there's so much that we haven't covered.
Yeah.
Dr. Morthy, you get to go first. And
Great.
again, feel free to talk with each other, on top of each other, etc. Because
So,
this is
yeah.
also the
Usually
place
do
where the
that.
magic happens. Yeah.
So we've talked, we've talked a little bit about what he and I both do for sick patients in the hospital. I want to talk a little bit about what I want to do for the El Paso community on an outpatient basis. What are we making available to El Paso Children's that really prevents kids from going out of town? Okay, pediatric interventional radiology is a clinical specialty. We want to have a clinic. That clinic is going to be a subspecialty clinic that involves a pediatrician, a pediatric dermatologist, a plastic surgeon, a pediatric craniofacial surgeon, and me. Here we go. This is our multidisciplinary team. Why these people? Most pediatricians encounter benign tumors that are made up of abnormal blood vessels. There's different kinds.
Right.
Most pediatricians are comfortable treating them initially with medication. If they get more complicated, that's when we come in.
Right.
Dermatologists sometimes, and we have 2 pediatric dermatologists in town, by the way, we're very lucky to have them, they sometimes encounter a child that has a weird skin lesion. That skin lesion turns out to be another collection of abnormal blood vessels or a blood vessel tumor. These are the kind of abnormalities that I'm interested in treating. Almost every children's hospital has what's called a vascular intervention clinic,
Okay.
a multi-special team that says, hey, these tumors are called hemangiomas, there's a whole bunch of different kinds, and then there are these things called malformations, collections of abnormal blood vessels, like the one we talked about in the arm, the fistula that caused the heart failure. These kids almost always can be managed with either medication or some sort of conservative therapy. We have a bunch of nice biologic therapies that we use. Our hematologists, who also treat cancer, are also very good with these medications. Some of these very aggressive blood vessel tumors actually respond to medication. But when they don't, that's where I come in.
Right. Okay.
Now we're talking about doing an interventional procedure, going through the groin or the arm, doing an angiogram. An angiogram is just a map of the blood vessels. That map tells us what do the blood vessels look like, how fast is the flow, is it shunting, is it going to abnormal places,
Interesting.
and then the decision, can we block off the blood vessels safely?
Okay.
That is what I really care about. And number 2, anywhere else in the body where there's an abnormal blood vessel. Just 3 weeks ago, we had a young child, 11 years old, present with high blood pressure.
11 years old.
11 years old.
Okay.
High blood pressure was caused because the artery going to his left kidney was narrowed. When the artery is narrowed, the kidney thinks the blood pressure is too low. It pumps out a hormone that raises the blood pressure.
Right.
Beautiful, right? We go in through the groin,
Right.
go into the artery, make a map, take a balloon, open up the artery.
Does
So
it work?
It
Boom.
worked. I saw him 2 weeks later. He's off of one of his blood pressure medications. Now, this one happens to have some more problems we need to fix. But that's the kind of procedure that we need the team to build around. Okay? I just
right.
had the pediatric dermatologist send me another case that we're going to schedule for a combined, what I do, embolization,
Right.
and then a plastic surgeon comes in and takes care of the other part.
So let's talk about this balloon for a second.
Yeah.
The balloon goes in there, blows up the vessel a little bit. Does the balloon stay inflated? Do you
no.
just go in there? Does the vessel then say, again, physiological, it's my favorite word.
Yeah, yeah.
Does the vessel say, okay, well, now that you've blown me up a little bit, now that I know I'm supposed to be this stretched out, will the vessel then, for the most part, stay that size?
Beautiful
or
question.
Or is there a stent that goes in there?
Perfect question.
Okay.
So you've basically covered it. It depends on the disease process that caused it.
Okay.
And we know which disease processes in kids cause these things. I think I know what disease this kid has. I think he has a genetic disease. We still have to prove that. It turns out, depending on the cause, whether or not it stays open when I balloon it, depends. There's a certain rate. I already checked him 2 weeks later with an ultrasound. It looks like it's open. I'm going to do what's called a CT angiogram next to see whether it's really stayed open enough. If it looks good, great. I'm going to leave him alone and follow him up and take him off of the blood thinners I have him on. If it doesn't look good, I'm going to go back and put a stent in.
Oh, okay.
So it's a thing that we don't like to do in kids, because once you put a stent in,
it's in.
it's in, and I can't take it out. And he's 11, so he's going to grow a little bit.
Right.
So I'm going to try to avoid doing that.
So the reason I asked that, and you hit it too, is a stent, because then your body wants to, grow around the stent. It, puts its little tentacles in there, and the roots grow. And so when we're talking about kids, and I'd like to talk about cardiology stuff too.
Sure.
With stents that have to be put in when you're young, they're not able to be taken out, but then you can go later and then re-put in another stent, either close by or where that stent is, if that is not, because again, I'm thinking 11, let's say he's 4 though.
Yeah.
Let's say he's really small.
Yeah.
And 11 is already kind of old, but now that stent is like, okay, I'm a little small.
Yeah. So these are the most important questions we are asking in our fields. Now, the holy grail of stenting is biodegradable stents.
Nice.
And they have them. We
Right.
don't have them in this country yet, but they are putting them in coronary arteries, the arteries to the heart, in some places as part of clinical trials.
Okay.
These are made up of sugar polymers of various kinds, and he's the chemical engineer. He'll explain it to you. But bottom line is, this is what I'm waiting for in kids. Because in kids, for example, I think a couple of years ago, we had a child who had a gunshot wound to his shoulder. An abnormal connection formed between 2 vessels. The only way I could close it off is to put a stent in the artery that goes to his arm. The stent that's covered, by the way. It's called a covered stent.
Okay.
Well, I didn't want to do that, but I had to, right? Now, that artery is not going to grow to serve the
Right.
need of his arm growing.
Exactly,
So we got a problem. I would have loved to put in a biodegradable stent, put it in there, open up
Right.
the artery, shut off the connection, and guess what? It dissolves in 6 months.
It dissolves, right.
Now,
right.
that is beautiful,
Yeah.
but we're not there yet.
Okay. Some countries are, though, and we're going to get there. So, Dr. Ross, again, that's like a wide open question. What
Yeah.
would you like to speak about that we haven't talked about yet?
Well, I was thinking, one thing that people don't get a chance to talk to radiologists that often, and so they probably just don't even understand what it is we do. And it's true, we've been talking a lot about pediatrics, and that is our specialty, that's our love. But I just kind of like to describe for your audience what a radiologist is and why they should care. So when I went to medical school, I looked at all the different specialties, and I was trying to decide what I would like to do. And I found radiology, and I found radiologists who were deciding what was wrong with people as they were coming into the hospital. And so a lot of patients, they never meet us, never know us. They may see a report with our name on the bottom. Some do see us and meet us in procedures we do, but we're part of the hospital that helps decide what's wrong. And we've been trained specifically to deal with imaging. So we train not just in physiology, anatomy, pathology, all those things. We do all of that. We learn all that. But we also learn physics.
Right, exactly, all the technical stuff.
Yeah, exactly. Biophysics, all those things that let us decide what's the best imaging for the patient. And then once we get the imaging, what are the things that are real disease and what are just things we call artifacts?
Right.
What are things that just look wrong but aren't really wrong with the patient? And so
These could be like the chronic but benign
Yeah.
situations, right? I mean, something that your body is what it is, but it's benign, it's
too.
not going to hurt you.
Yeah,
It's
there's-
just who you are.
There's anatomic variants that just how you look on the inside is a little different than other people, but it's not pathology. But I think it basically, if you get an X-ray and it's looked at by, let's say it's just for a pneumonia or something, maybe only the family practice doctor looks at it. That's different than an X-ray you get at the hospital where like, okay, we're trying to decide if there's congenital heart disease or
Right,
something.
right.
And so we're specifically trained. We're trained for many years. It's a long specialty to do this. And so I was really excited when I met Dr. Morthy when I came here to interview, and he was doing these cases and all that. I'm like, okay, this is great. I want to come here and do this. But yeah, so anyway, just people might be asking, like, who are these guys? And
who are
I've
these
never
guys?
even heard of radiologists.
Well, I love the story when we were talking about, I mean, you were here before and you guys interviewed it, and but to me it's the teams. And I'd like to take just a minute because and I know you touched base on it when we started on air, but before that you were really talking about this subspecialty, which becomes a subspecialty, and sometimes a subspecialty. And I don't want to go too crazy about it because I know we're about to wrap up, but I would love for the audience to understand, like you said, there's so much going on. You've got all the medical stuff, but then you really got to keep up with technology. And every 6 months, there's something new going on. Like you were talking about this biodegradable stent, right? I mean, maybe we have this exact same show next year and you're like, hey, guess what we got? Guess what I got to do a week ago?
Hopefully.
You know, I'd love for you to kind of talk about the subs really quick.
Sure. So a radiologist in general, Dr. Ross has already explained. Our commitment to El Paso is that when your child, God forbid, needs to come to our hospital and needs any kind of radiology testing, we want to make sure that there is, number one, a pediatric neuroradiologist, a specialist who's not only a radiologist, but a specialist in imaging of the brain and spine and head and neck. That is a separate subspecialty, and that helps the neurologist and the neurosurgeon. We want to make sure that there's a pediatric advanced cardiac imager, got one. We want to make sure that there's a pediatric interventional radiologist, got one that's getting a little older. We want to build a team of radiologists that not only do the general stuff, but do the advanced imaging stuff that prevents kids from having to go out of town.
Right.
And that way, the neurosurgeon and the neurologist can work with the pediatric neuroradiologist, the cardiologist and the cardiac surgeons and the interventionalists work with the cardiac imager, the vascular surgeons, the dermatologists, the pediatric surgeons work with the interventionalist. And really what ends up happening is you have the highest level of expertise available in one place.
Right.
And we're talking to each other.
Right.
And because we're forming a team, we're committed to working together to elevate the level of care. That's what being teams is about.
And I liked what Dr. Ross said earlier, and it's always amazing to me because when for example, you two, you bounce off each other beautifully, and you can tell there's camaraderie here.
Yeah.
And you said sometimes, you know, some of the specific cases, are you guys just talking over the lunch table going, yeah, I'm having an issue with this. And I remember years and years ago, we were talking about the tumor board because I thought, what's the tumor board? I just thought that was the most odd thing. But from then on out, I try to with every one of these shows, even if you have the exact same titles, there are all the teams that come in, and it could be, you know, nurse so-and-so that saw something 12 years ago, and I remember this, and that's how a problem is solved. Yeah. So kudos to you guys. We're wrapping up. I have no time for another question, but I do want to say for all of you that caught this either at the last moment or didn't have enough time to write things down, you can watch the show back 2 different ways, actually 3 different ways. We stream live on YouTube, so you can go to YouTube and look up the El Paso Physician, have to word the El Paso Physician, and then you can find this episode and other episodes as well. You can also do it with pbselpaso.org, pbselpaso.org, and just look at local programs, find the El Paso Physician, or you can also do it with the El Paso County Medical Society. Just go with their acronym EPCMS.com, the medical societies.com, however, and then you can look up this program. And sometimes it just goes too fast. And Brenda, I want to say thank you again for all the questions. This is a live program on Thursday evenings, but I know it gets aired back several times throughout the month and then throughout months too. So again, if you need to find this again, feel free to look. We've been talking with Dr. Aaron Ross and also Dr. Chet Morthy, both of them from the El Paso Children's Hospital, again, underwriting the show for this evening. And every single month, several times a month, the El Paso County Medical Society comes to the board. They bring me the questions, they bring me the doctors, and all I do is do a little bit of research and get to play and have fun with you guys and learn all kinds of things. Thank you so much for watching. I'm Catherine Berg, and this is the El Paso Physician.